Thank you very much, Angela. Ethan, good to see you. Good to see all of you. It's an impressive society, my first meeting with you. A great privilege to have the opportunity to deliver this lecture. And my goal actually is to provide an optimistic view. Before I do that, I have to disclose that, as was noted, I am a Section 16 officer of Merck & Company, was previously that at Amgen, and nevertheless I try to approach these questions in a balanced way. Okay, so I will stipulate at the beginning, in case there was any ambiguity, that great drugs change the world. They do, and they have. And we all know this, but we actually don't spend an awful lot of time thinking about it. You know, we know it because essentially everybody in this audience was exposed to childhood vaccines that meant that they didn't suffer from a lot of childhood diseases, many of which otherwise could have been fatal. We know this because of the availability of antibiotics, beginning in the middle part of the last century and continuing to the present, a constant battle for those of us in the biopharmaceutical industry. We know this because of the development of effective therapies for cardiovascular disease, and in particular for the prevention of cardiovascular disease, that have resulted in the near complete elimination of coronary care units, which were places that I spent a lot of time in back when I was practicing medicine. Those include antihypertensives, of course, and cholesterol-reducing agents, vasodilators, a whole variety of different important drugs. And we know that because of the availability of modern anti-neoplastic agents, there is a huge effect on the health of individuals who unfortunately are stricken with cancer. Great drugs change the world, but I have some hard news for you, and that is that although we can generate prophylactic vaccines that dramatically reduce risk factors for malignant disease, as for example the HPV vaccine, which I had the privilege of being involved with 20 years ago, and the next generation version of it, the 9-valent Gardasil 9, which we registered just a couple of years ago. Despite the fact that we can do that, and despite the fact, as shown from this publication a month and a half ago from the CDC demonstrating in the United States, a 64% reduction in HPV infection in girls as a result of the availability of this vaccine. By the way, in the United States, we don't vaccinate terribly well. So if you were to go to another place that vaccinates much better, let's say Rwanda, for example, then you would find a much more dramatic reduction. Despite the fact that we can do all those things, there's a problem, and that problem is represented on this slide, which is a slide that is taken from studies initially conducted by Bernard Munoz, data that was assembled by Peter Tolman at the Boston Consulting Group. And what the slide shows you is the number of new molecular entities. These are the registration-worthy molecules that are produced by the biopharmaceutical industry, for which there is patent protection because they're novel, non-obvious, and useful, and in general are compounds that have never before been seen on the face of the earth. These new molecular entities are the things that make drugs that change the world, and the number of new molecular entities so registered produced per $1 billion of investment in R&D has declined exponentially for more than 60 years. Exponentially. We crossed a milestone around the year 2000 when you got now just one new molecular entity per $1 billion invested. And we're now at a point where it's somewhere around one new molecular entity requires about $3 billion invested. You have a look at this thing, and remember that during this period, roughly 3 generations of research scientists conducting their work, good people, smart people, thoughtful people, well-trained people, and over those 3 generations, there's been an exponential monotonic decline in productivity. It's kind of like a physical law. It's like the second law of thermodynamics. You know, the universe is always expanding, entropy is increasing, and productivity in the pharmaceutical industry is always declining. That's a problem. That's a problem for us because if great drugs change the world, as I stipulate, then we need to do a better job of making them. And now, having told you that, I need to tell you why I'm so optimistic. So the reality is that in our world, biology drives technology, which drives computation, which drives innovation. And this is a sort of phrase that we use at the Institute for Systems Biology, with which I've been associated now since its founding about 15 years ago. And what we know is that the study of biology, as you heard from Nicole just a minute ago, and from others in the presentations that I was privileged to sit through beginning this morning, the study of biology generates new biological questions which drive the development of technologies. This has been occurring at an accelerated pace since the availability of relatively primitive research tools in the 1920s and 1930s to the present time, where we have the opportunity to examine biology in molecular detail. And those technologies lead to the development of computational techniques that generate new hypotheses, which drives biology in this virtuous circle. We've seen it over and over this morning. We see it over and over in the literature that we read every day, and it matters. And just as an example, let's look at this slide, something which is, at least in general, sort of familiar to all of you. This is a slide where we look at the expression of all of the genes in the human genome, at least all of those things where we can measure polyadenylated transcripts. And we're looking at a comparison between normal skin and psoriatic skin in patients and inventorying all the genes. The plot is, on the abscissa, the amount of RNA expression versus, on the ordinate, the ratio of expression in disease versus normal. And you can see among the roughly 22,000 or so transcripts that are identified, you can see that some things go up and some things go down and some things stay the same. And what you're shocked by, and this is a study that Brian Kotzen supervised at Amgen some years ago, what you're shocked by is how many genes change. But we were able to use this kind of analysis as a molecular diagnostic tool to inventory different cytokine-specific reagents that could potentially be useful in the treatment of psoriasis. Having pioneered the use of a TNF sequestrant, etanercept, as a way of reducing the impact of psoriasis in human populations, we asked the question, what sorts of things could we do that would actually work better than sequestering TNF? And you know, here's the winner. So you can see this, basically the same slide. This is taken from 6 different subjects who were evaluated and treated, and there's an integrated analysis of RNA expression. You're looking again at the log ratio on the left-hand side, and then you're looking 2 weeks post-treatment, and the treatment is really dramatic because the, let's say, pathologic, and in some cases epiphenomenological changes in RNA essentially completely normalized within 2 weeks after systemic treatment with a cytokine suppressive therapy. Anybody want to guess what therapy it was that worked best? It's IL-17 antagonist. Quite impressive. And that, of course, leads to clinical studies that can have a big impact, and for all of you who treat psoriasis, these do have a big impact. Okay, so how can we apply this in the oncology setting where we've recently learned, despite now more than half a century, really a century of speculation about the role of the immune system in the control of cancer, we've recently learned that it is possible to manipulate immune cells in such a way that one affects the growth and persistence of tumors. What we've learned, and I would say certainly I've learned over years of trying to make anti-neoplastic agents, is that if we focus on the cell-autonomous parts of cancer, that is, the specific mutations that result in changes in genes that affect substrate adherence, growth factor dependence, those kinds of things, that we can have an effect when we plot overall survival versus time, but it tends to be fairly modest because of the rapid emergence of cells bearing other mutations that aren't affected by the drug. And the goal for immune manipulation, of course, is to change the shape of this curve so that at least a fraction of individuals have long-term and durable survival because of the persistence of immune cells directed against the tumor. And of course, through combinations of immune manipulations, and immune manipulations combined with other things, one hopes to actually elevate that curve so that it behaves better. Okay, so where are we in this kind of exercise? Well, one thing we can say is that this is a wonderful period to be studying immune manipulation of malignancy. And there are at least 5 different categories of manipulations that are proving to be effective. Parenteral immunization with tumor antigens is probably the least effective. I guess they think I'm going to be thirsty here. Parenteral immunization with tumor antigens is probably the least effective. But there's been quite a bit of success with in situ immunization with viral vectors, and I'll talk about that in just a second. Redirected lysis, in which one creates an antibody typically that on the one hand binds a target sequence and the other hand binds the T-cell antigen receptor, that has proved to be quite effective. And also, as we heard earlier today, chimeric antigen receptor bearing T-cell clones can be quite effective, particularly in hematologic malignancies. The most effective, of course, is checkpoint inhibitors. We'll talk about those in a moment. Let me show you something with viral vectors that some of you may be familiar with. And this is one that we spent some time working on again at Amgen, which is a herpes virus that Rob Coffin at University College London had cloned actually from the lip of one of his technicians. It's a time-honored principle. At any rate, he cloned this virus and then engineered the virus so that it would preferentially infect and destroy rapidly dividing cells. He inserted 2 cassettes that permit the expression under a CMV promoter of human GM-CSF as a means of drawing in inflammatory cells, and also did things to the virus that would reduce its neurotoxicity. The virus is called by shorthand T-Vec, and T-Vec, the general strategy for T-Vec introduction is shown on the slide, where, in essence, one infects a visible population that would include both healthy cells and malignant cells. The virus should preferentially replicate and destroy malignant cells. In replicating, it should also produce GM-CSF, and as a result of this, there will be the attraction of antigen-presenting cells, and T lymphocytes will attack residual cancer cells. That's the goal. Here's what it looks like clinically. So this is one example from a patient that we had the opportunity to study who had a recurrent lesion of the scalp and 2 small lesions in the liver, which you can see by a PET scan. And in this individual, the therapy is administered by directly injecting virus into visible lesion. The virus is largely contained locally, and there's relatively little systemic spread for a variety of reasons. And you can see that in addition to the elimination of the local lesion in the scalp in this case, as a result of in part, the direct cytopathic effect of the virus, there's also an abscopal effect, which is to say that the lesions in the liver actually themselves disappear, though they were never injected and were never infected. And that result prompts a much larger set of studies, and I'll show you that study here. This was the basis of registration for this particular virus, which is available to treat advanced melanoma. And what it shows is a plot of time in months versus the time to treatment failure. So what you're looking at is treatment failures in populations who are either treated with subcutaneous GM-CSF, which not surprisingly had very little effect, versus the direct administration of the cytolytic virus, the oncolytic virus, into visible lesions in patients with advanced melanoma. It's an interesting place to start, and I think it will prove to be something that can be used in combination with other agents, but not by itself good enough. It tells you something, though, about the ability of stimulated T-cell populations to engineer remissions and maybe durable remissions in patients with advanced malignant disease. And recently, that's become a much, much more profound area of inquiry as a result of studies on checkpoint inhibitors in the replication of T lymphocytes. So there exists a fairly large set, some of which are noted here, of activating and inhibitory receptors that work in concert with the antigen receptor on T cells in order to either promote activation or suppress activation. And these are natural targets for intervention for those of us who try to manipulate the immune system. Virtually all of these have been studied in some detail. Many of them are being studied clinically right now. But the effective targets that we know about are first CTLA-4, the study of which was pioneered by Jim Allison and his colleagues and subsequently led to the development of ipilimumab, which is an effective agent for the treatment of advanced melanoma, and then PD-1. And PD-1 has proved to be the best target overall. There are 2 registered drugs that target PD-1. One of those is called pembrolizumab and is made by Merck, my company, and the other is called nivolumab, and it's made by Bristol Myers. And both have been studied in quite a lot of detail, and I'm going to summarize some of those studies and then talk about where they lead us. So first of all, just in general, as I mentioned, the T-cell antigen receptor recognizes its cognate antigen, which is presented as peptide in the context of major histocompatibility complex molecules. And when it sees a signal from either PD-L1 or PD-L2, which are 2 ligands for PD-1, there's an inhibitory response such that even though the antigen receptor is engaged, T-cell activation does not proceed, or at least proceeds poorly. You can demonstrate that directly in a dish, you can demonstrate that in an animal model, and you can demonstrate that in human cell populations as well. And beyond that, you can also show that by blocking the inhibitory signal that comes from PD-1, you improve lymphocyte activation, and get this, you reveal the pre-existing immunity in many cancer patients and cause the elimination of even very large, very bulky tumor masses. Blocking PD-1 reveals pre-existing immunity. I have to say that over and over because if you had asked me 10 years ago whether such a thing was possible, I would have said, absolutely not. But it is. And here's an example, one of the first. This is a slide from Tony Rebus at UCLA, and it shows a patient, a 72-year-old man with a very large intrathoracic mass, a left thoracic cavity mass in the mediastinum and in the pleural cavity. And this individual was really in pretty desperate shape at the time that they received PD-1-directed therapy. And you can see in the matter of just a few short months, the mass virtually completely disappeared. So this is the treatment of advanced metastatic melanoma with systemic therapy with, in this case, pembrolizumab. It's quite remarkable. And as we looked at a large set of individuals with advanced melanoma, patients who were either treated with ipilimumab, which by then had already been improved, or patients who were ipilimumab naive, 3/4 of those patients had demonstrable reductions in tumor mass. And you can see a lot of those reductions, and this is called a waterfall plot for those of you who are not familiar with it, where we look at the change from the baseline measurement in the sum of the linear diameter of target lesions, and we look at a bunch of individual patients, and they're organized such that those who have no change are on the left and those who have a lot of change are on the right. You can see in that waterfall that a lot of patients are being affected, and an awful lot of patients have a dramatic reduction in the size of their tumors. And that dramatic reduction in the size of their tumors translates into improvements in overall survival. The plot I'm showing you is from the phase 3 study demonstrating the superiority of PD-1-directed therapy with pembrolizumab to ipilimumab, which is directed against CTLA-4. Now, when we did this study, which was just published last year, when we did this study, ipilimumab was the best available therapy for patients with advanced metastatic melanoma. But you can see that at 2 different doses, shown in green and red, overall survival is improved and improved dramatically compared to ipilimumab, which is shown in purple, in patients with this disease. And at the American Society for Clinical Oncology meetings next month, we'll have the opportunity to describe the persistence of that effect, which is really quite impressive and quite encouraging. So there are a couple of things that I should mention at this point, and that is pembrolizumab, which is a marketed drug, as Keytruda, is not without adverse effects. And no one should believe that one can treat cancer patients with a drug that does this kind of thing and see no adverse effects. In addition to systemic symptoms, fatigue and anorexia, which are usually fairly mild in nature, people develop autoimmune disease, maybe unsurprisingly, and that autoimmune disease is often directed, for example, at endocrine organs. Hypothyroidism is the most common of them. Hyperthyroidism is sometimes seen, and in addition, there are some cases of Addison's disease and other things. There is autoimmune colitis, and in some cases, autoimmune pneumonitis, particularly in those individuals who have received or do receive radiotherapy. So these patients have to be managed quite carefully. Nevertheless, compared to conventional cytotoxic chemotherapy, pembrolizumab is exceptionally well tolerated. So you can say, well, that's nice for metastatic melanoma, which after all is a tumor that has been known for a century to undergo spontaneous regressions that were believed a century ago to be immune-mediated. What about other cancers? We're in the process of conducting what is the largest oncology therapeutic intervention program in history, with more than 20,000 patients on study, more than 30 different tumor types, more than 270 studies registered on clinicaltrials.gov. And I won't summarize it for you. But I will say that pembrolizumab monotherapy shows activity in most tumors that you select for screening. And here's a set of little mini waterfall plots just showing you small samples, typically in the range of 30 or so for the small subjects and several hundred for the ones that are large, where we've looked at response rates in patients who are treated with pembrolizumab as monotherapy. This is monotherapy. Most of these patients have been multiply treated with many different cytotoxic regimens previously. Melanoma is shown in the top left. You've seen that plot before. Non-small cell lung cancer is the next one over, 262 patients, clearly monotherapy responses. The same is true for head and neck cancer, where the responses we felt were good enough that we've submitted that for approval by the FDA. We'll receive priority review, and we'll see how that goes. Urothelial tumors in the top right, triple-negative breast cancer, bottom left, gastric cancer next to that, classic Hodgkin's lymphoma. Nearly 90% of patients respond in that setting in classic Hodgkin's lymphoma, and the far right is primary metastatic B-cell lymphoma. What I'm telling you is that PD-1-directed therapy is the first broad-spectrum anti-neoplastic therapy ever introduced into clinical practice by this criterion. It's amazing. But in a sense, it's no surprise, because we aren't actually treating the tumor, we're treating the host. We're treating the immune system, and the immune system is remarkably able to identify these tumor populations and in many cases to destroy them. If you look at pembrolizumab therapy in previously treated non-small cell lung cancer patients compared to taxane therapy, docetaxel in this case, you can see that treatment with pembrolizumab as a single agent is superior in terms of overall survival. These data were published at the very end of last year, and quite similar data have been obtained by our colleagues at Bristol Myers using nivolumab. This study is showing you previously treated patients who have PD-L1 expression on their tumors, which is a biomarker that we use to enrich for response. And in this case, a lot of the tumor cells express PD-L1. The same kind of thing is seen in this very busy slide that was presented from our Bristol Myers colleagues. And what it shows you is that if you look at the top curves, you're seeing patients whose tumors express a lot of PD-L1, and the nivolumab-treated patients in blue do much better than the docetaxel patients shown in green. But if you look at those who don't express much PD-L1, that's the bottom set of curves, and particularly the one bottom left, you can actually see that during the first 6 to 9 months of treatment, patients are better off receiving chemotherapy than receiving nivolumab therapy. We observed the same kind of thing. And what it tells you is that you can begin to stratify and identify which patients will respond. And that's a first step, I think, to understanding how we can make responses better. And instead of being able to engineer responses in roughly 25 to 30% of non-small cell lung cancer patients, just picking them at random, more than 50% if they are high PD-L1 expressors. But instead of that, we want to get to the point where virtually everyone has a good response. We're using nanostring-based techniques to, in an unsupervised way, identify biomarkers that could be helpful. And we've been able to come up with some quite interesting signatures that enable us to identify pembrolizumab responsive patients. A key feature of pembrolizumab responsiveness appears to be the representation of mutations within the tumor cells, presumably because those mutations permit the production of neoantigens, which the immune system can recognize. The slide shows you a very familiar plot that shows you the distribution of mutations as a function of tumor type, all the tumor types listed. And there are some tumors which have a lot of mutations, guess what, melanoma all the way over on the right-hand side, and others that have very few. That suggests that mutagenesis applied to the tumor could make tumors much more recognizable and improve the results when treatment with pembrolizumab is instituted. There's other data to suggest that as well. In a study that we conducted in collaboration with Bert Vogelstein and colleagues at Johns Hopkins, what we and really they found was that if you look at patients whose tumors have mutations that result in deficient mismatch repair, in this case colorectal cancer, colorectal cancer is relatively resistant to pembrolizumab treatment, but in patients who have mismatch repair mutations in their colorectal tumors, shown in the green, there are a lot of responses. And there are responses also in very resistant non-colorectal cancer patients where mismatch repair is deficient, for example, in pancreatic cancer. The same observation has been made, interestingly, in a skin tumor, the Merkel cell carcinoma, and we'll see that in a minute. What you see is that if you look at colorectal cancer as just one example, the patients in whom there is an objective response, looking at the right-hand panel, have a lot of somatic mutations per tumor, that's the green bars, and those who have progressive disease have relatively few. In the Merkel cell population, and this is a slide that I obtained from Paul Niem at the University of Washington Cancer Immunotherapy Trials Network member, pembrolizumab results in a dramatic reduction in tumor size in patients who either have the Merkel cell virus or don't. And in those who don't have viral antigens, when you examine those, you find that those who are responding are those that have the highest representation of neoantigens. So, where are we? Here's the summary. It's pretty simple. Naive T cells, they recognize antigen-presenting cells or tumor cells. They become activated T cells. They have co-receptors on their surfaces. And we could manipulate those such that those T cells become either anergic T cells or become activated T cells. And that's what we want to do. The balance is shown on the bottom left. We already have some insight into how to do that. But when you consider the circuit diagram of these things, it gets a little bit complicated. This slide is from actually 10 years ago, just looking at toll-like receptor pathways. It reminds you of those metabolic intermediary metabolism charts that they used to put on the walls of laboratories. Completely impenetrable. 10 years later, you can imagine it's much worse. And you may despair for the ability of reductionist science to give insight into such pathways. I don't, because fundamentally I know that basic research is the only means to improve therapeutic interventions. And we do this because by asking focused biological questions, developing new tools, and applying high-quality computational techniques, we can reveal the truth about tumors, about immunity, about the human condition, and create better therapies. So we have to get back to this slide, because the slide shows you that there's been a negative return on pharmaceutical R&D investment for an awfully long time, and in particular in that blue bar there's a lot of investment beginning in the mid-1990s, continuing to the present. Can you blame me in my optimism if I don't look at the little tail at the end and imagine that perhaps we're beginning to bend the shape of this curve? we're certainly having a big impact on human health. And it's because of the work that you do, the work that your colleagues do, and our ability within the industry to translate that into something meaningful. Thank you so much for your attention.